All right, so this is part 2 of chapter 19 notes, and this is about essentially the physiology of how the heart works. We've talked a lot about the anatomical structures, where they're located, um, purposes, differences, and things like that. Now we're going to talk about how the heart actually beats to pump blood through the body. So the heart is very unique in the fact that it can conduct its own electrical impulses. It doesn't need to be told to do so from the brain. So it has its own what's called conduction system. The cardiac muscle cells are specialized. They have their own messages sent through them. And these cells in the heart, they're a specialized group of cells. We're not talking about the muscle cells themselves. We're talking about a different subset of cardiac muscle cells. And they are part of this conduction system. So essentially, they determine how fast the heart should beat, or how slow it should beat, and when it should beat. And this is the pathway that is taken through these specialized muscle cells. It starts in the SA node, sinoatrial, so it's in the atrium on the right side. This is known as the pacemaker of the heart. If somebody has an artificial pacemaker put in, it is taking the place of this. Essentially, that SA node in their heart isn't working. And then the message passes to the AV node, which is at the floor of the right atrium, right by the AV valve. And the message will then pass to this area called the bundle of His, down the septum, the interventricular septum, and then it will divide, and it will go up these Purkinje fibers on the left and right side of the heart, at the heart's apex, and it will go back over the walls of the ventricles. It's best described in image form. Here is the SA node. This is the pacemaker. The message will spread then to the AV node. AV node passes it down the right and left bundles down in the septum here, and then it will pass from the apex up Purkinje fibers, and the Purkinje fibers are both on the left and the right and left ventricles. So this isn't actually the pathway of the heart contracting. This is the pathway of the message to tell the heart to contract. This is the conduction system. So the conduction system, what we just talked about there in yellow, initiates or starts and propagates or sends an action potential, a message. These muscle cells fire action potentials. They depolarize, they repolarize, etc. So again, this is the pathway. The cells in this area of the SA node have a special name they're called nodal cells. And they will initiate. So it'll initiate a message to contract about 75 beats per minute. SA nodes are autorhythmic, meaning they depolarize spontaneously. They change, their sodium gates will open spontaneously to start a message. An average heartbeat is 75 beats per minute because the action potential starts about 0.8 seconds, every 0.8 seconds. And this just is a graph that shows how the resting membrane potential is about -60, and it will spontaneously, somewhere in that range, depolarize to produce a heartbeat. And this is just, again, more detailed of the same thing that we're talking about here. So the action potential starts at the SA node, okay? It will spread through the atria until it gets to the AV node, which is by the AV valve, the tricuspid. And the two atria, the message is spreading over the surface of them at the same time. When it gets to the AV node, the message to contract slows down. And this is because there's a smaller diameter of cells in that area. So it gets kind of bottlenecked, so it has to slow down. But this is good news because there's this delay that allows the ventricles to totally fill with blood before they contract. And then it will pass from the AB bundle in the septum, right? And it will travel up, using my nose as a heart, up the Purkinje fibers along the sides of the ventricles. After that, and then it will spread through the ventricles, the message, and then the ventricles will contract. So let's do that again. Action potential starts in the SA node. And then it will get to the AV node, atria will contract. The message slows down until all the blood gets in to the ventricles, okay? And that's at the AV node. Then it will travel through the bundle branches in the septum, up the sides of the ventricles, which are the Purkinje fibers. Once the message goes all the way through the ventricles, then the ventricles contract. And this is all of that in picture form. Notice the words there. So if you need to, look at the arrows, read the pictures so you can understand what's happening. There's the message going through the atria. Next, it's going to slow down here, allowing blood to fill the ventricles. And then the message going down the septum, up the sides of the ventricles. Okay? And so on. So some specialized features with the ventricles. So I said the message slows down when it gets to the AV node, but the Purkinje fibers, which are on the side of the ventricles, are larger in diameter. They're larger cells than cardiac ones, than the other ones. So the action potential spreads really fast through the ventricles. And this gives a powerful all-at-once contraction to the ventricles. The muscles in the inside wall of the heart, called the papillary muscles, are stimulated to contract immediately when that message goes through them. And then, of course, they're attached to the chordate tendineae that help keep the valves shut and keep them taut, or tightly shut, to hold the pressure within the ventricles. And they open when pressure overcomes that, which we'll talk about in a little bit. And the stimulation, so this is my heart. This will be my apex, okay? So it's the bottom of the ventricles. The message or the contraction will start at the ventricles and move its way up along the side. So it'll squeeze the apex up. Look up some videos of hearts contracting. I'll show one as well, but it contracts when you see it. The atria contract together at the top, and the ventricles contract together at the bottom. And when the ventricles contract, it's like a go-gurt. Okay, they squeeze from the bottom up to get the blood out of the heart. A heartbeat can be graphed on graph paper, and what that is called an electrocardiogram. We can get a graphical representation of the electrical activity produced by the heart. You can actually detect the signals from the heart via electrodes that you can place on the skin. And this is a common diagnostic tool to detect heart valve problems, heart attacks, different things like that. And there are 3 waves to it. The first wave is produced when the atria, that message goes over the surface of the atria, or they depolarize. The QRS wave is produced when the ventricles depolarize. And at the same time, the atria are repolarizing. And the third wave is produced when the ventricles repolarize to get to that rest state. There's also certain segments. Before we get to that, here's the P wave. So the atria depolarize, then they contract. Ventricles depolarize, then they contract. So this segment, the PQ, is when the atria are actually contracting. This ST is when the ventricles are contracting. And then the T wave is when the ventricles are relaxed. The PR interval, so we're talking from here to there, top of the first wave to the top of the second. This is the time to transmit the action potential through the entire conduction system. So from the atria to the ventricles to get that message through the heart. The QT, you're a cutie, is from that wave to that wave. And that is the time from the beginning, to the T wave, reflects the time of the action potentials of the ventricles. The length of that depends on your heart rate, how fast your heart rate is. So let's look here. So the QT, if your heart rate's really fast, it's called tachycardia. So it's boom, boom, pause. So normal, beep, beep, pause. Lub, dub, pause. Lub, dub, pause. Lub, dub, pause. If we increase the heart rate, that would be tachycardia. If we slow it down, that's a cute picture. It's called bradycardia. Tachycardia, or tachyarrhythmia in this case, so it's a rapid and irregular heart rate, can be detected on looking at a QT interval. There are many conditions that can be diagnosed when looking at an EKG. We will get a chance to look at your EKGs. Don't be surprised if they don't look perfect, because not everybody's heartbeat looks exactly like the pictorial representation. A trained cardiologist knows how to read it though, so that's good. This again just shows here changes in the atria that happen on a graph and the changes in the ventricles. So when your heart beats, one heartbeat, that's one cardiac cycle. It's all the events that hurt from the start of one heartbeat to the start of the next. That's called the cardiac cycle. And it includes two different phases. Systole, when you see that word systole, think of squeezing or contraction. And diastole, or diastole, I pronounce it both ways, is relaxation, so it's the opposite. When your heart contracts, either the atria contract together or the ventricles contract together. When that happens, a pressure increase happens somewhere else in the heart. So contraction increases pressure, and relaxation decreases pressure. And blood moves from its pressure gradient. So blood will move from the atria to the ventricles when the atria have a higher pressure inside compared to the ventricles having a lower pressure. In the valves in the heart, the AV valves and the semilunar valves help prevent backflow, the blood going the wrong direction. So when we talk about the stages or the parts of a cardiac cycle, it can be split into ventricle systole and ventricle diastole. The ventricles are most important diagnostically, so that's why we name it based on that. So when the ventricles are contracting, it increases the pressure, so they're squeezing. When the blood is in the ventricles and they're squeezing, it's actually going to cause the AV valve doors to shut, causing the first sound. And then the semilunar valves will open, that pushes the blood out. When ventricles are relaxed, their pressure decreases. So now the semilunar valves close, and actually the AV valves open because blood's coming in from the atria again. When the cardiac cycle begins, before anything contracts, it's at rest. And blood is moving back into the atria passively. So the blood is just coming back in because it's always moving, always circulating. This is called the passive filling of ventricles. The AV valves are open, so in between the atria and ventricles, and the pressure in the atria is starting to build, and it's larger than the ventricles. And at this time, the semilunar valves, of course, are closed, because the pressure in the ventricles is less than the pressure that are in the aorta and the pulmonary trunk. There we go. Now I'm saying a lot of words here, and I realize that. You can pause me at any time, read it for yourself. You're going to have to look at the pictures to dig out the best information here.